Good evening, everyone, and welcome to tonight's webinar. We have a full house this evening, and thank you for joining us. For those of you that don't know me, I'm Tanya Nell. The order of tonight's proceedings will be Dr. Sulieman will present his presentation, and after the lecture, he will have a question and answer session. So feel free to load your questions during the presentation in the question column. After the question and answer session, I will share a few promotions with you on the Polar Tooth Whitening range. As a hygienist, I've had quite a bit of tooth whitening experience in my life, or my short life so far. And the worst feeling in the world is when you sit there and you pray the teeth white. So I've used the Polar range quite a lot over the last 2 years. And the combination of the Polar in-office tooth whitening and the Polar take-home night has given me a lot of good results. So the cost per patient is also very good. So more patients can afford tooth whitening or the tooth whitening experience. It's my pleasure to welcome Dr. Sulieman back after his informative lecture a few weeks ago, where he covered to bulk fill or not to bulk fill, or should we keep it smart or simple. If you've missed that webinar, it's available on our Facebook page, so go and watch it if you've missed it. And I would also like to thank SDI for sponsoring the evening tonight as well as the bulk fill webinar. So I'm just waiting for Dr. Sulieman to log on.
Hi there.
Well, welcome, Dr. Sulieman. Welcome back to the South African audience. I'm just going to give you a little bit of history about Dr. Sulieman. Dr. Sulieman graduated at the University College Hospital and gained his Bachelor of Dentistry degree with honours, and he completed his master degree at Bristol University in Restorative Dentistry in 2001. He is a practicing dentist in London at present, and with all that being said, last time we learned that he would rather be a pilot, would have been a pilot than a dentist, and he is a huge Liverpool fan throughout the ups and downs. With that being said, Dr. Munther, the floor is yours.
Thank you very much. Okay, look, good evening, everyone. Good evening in South Africa. I hope you have lovely weather out there. At least this time I don't have the rain on top of my head like last time. I'm just going to share my screen. Please let me know if you can see everything in a minute. And then after that, you can disappear to more enjoyable things to do than watch me. No.
I'll be listening closely.
Okay, here we go. Can you see the presentation?
Yes.
Now? Okay, perfect. Okay, so as I said, good evening to everyone. Just a little insight. Tanya just mentioned my MSc in that was in composites and things like that. I have a PhD in tooth whitening, which I finished in 2005. So I've been researching tooth whitening for quite a long time, and I've been lecturing on the subject for a long time. The reason I say this is because I'm here to share my experiences with you about tooth whitening, and also to let you know that there is a lot of scientific background to my lecture. I don't want to just make claims for certain things. I'd rather back it up with science, and that's what the lecture is based upon. So let's just get started and see what we're going to do tonight. Okay, so there's lots and lots of new things happening in dentistry, but the thing always stays the same. The appearance and color of teeth are a common concern for patients throughout any population in the world, and there is an improved need for tooth whitening throughout the world. That's been published in so many different journals. The other thing that you also need to be aware of is the tooth shade is the single most important factor to a lot of people with their smile. So you have lots of patients coming in thinking they want to move their teeth, they want to change the shape of their teeth, this, that, and the other. Where in fact, a lot of the times, it's the shade of the teeth that's going to make the biggest difference to them. So good old Gordon Christensen said, everybody in America wants to whiten their teeth to make them feel younger and provide them with a more beautiful smile. To be honest with you, it's not just in America, it's everywhere in the world. So there's been a few psychological studies that have been done on the color of the teeth and their whiteness and stuff, and they found that people were more favorably received in terms of the perception of people to be more attractive, more socially competent, even more intelligent, just by having whiter teeth. And the critical factor in the self-satisfaction surveys they've ever done in terms of a smile appearance is always been the tooth color. So it really is an important subject, tooth whitening, for any of your patients that are coming in and wanting to improve any part of their appearance of their teeth. So what are the whitening benefits? Well, we've already said the improved self-esteem is one important factor, but actually there's more to whitening than just the appearance. There is the oral hygiene and gingival health improvements that we're going to discuss. There's also the elements of caries control and caries reduction in vulnerable groups and certain groups, which I will discuss later on. So there's more to whitening than just making the teeth look nice. How does whitening work? What is the mode of action? How do we improve the whiteness of teeth? Let's first of all make a distinction between bleaching and whitening. Bleaching is actually the intrinsic change of color within the tooth, whereas whitening it could be just removing or controlling the extrinsic stains. So there's a big difference between that. So all these manufacturers of various mouthwashes, toothpaste and stuff, they can make whitening claims, yes, based on extrinsic removal of stain, but they can't really make whitening claims in terms of a bleaching, in terms of intrinsic change of color. So that's an important distinction. I'd like to just split things up for you and put bleaching into the classical home whitening, in-surgery whitening, and over-the-counter products. Now, I'm going to talk about bleaching and whitening at the same time. I will use, once I get going, I will use the term whitening to mean bleaching. But initially, let's make a distinction. So bleaching, the bleaching ranges that we have are anywhere between 5 to 16% carbamide peroxide, or up to 6% hydrogen peroxide for home whitening. I'm aware that certain countries in the world have stronger concentrations of carbamide peroxide, but in Europe, we have a European Cosmetics Directive that forbids us to use certain concentrations more than the equivalent of 6% hydrogen peroxide. So that is the reason for that, for this slide. In terms of in-surgery whitening, we have up to 6% here, but you have got, I think in South Africa, you don't have the same regulations, and you can have up to about 35% hydrogen peroxide, which is a much stronger solution than that we can use, and up to 16% or actually higher percentage of in-surgery carbamide peroxide used. With these products, it tends to be activated either using a light or actually chemical activation to make the product work. Now, we've also added to this category in terms of bleaching strips and wraps and paint-on products that are actually bleaching in effect, so they affect the intrinsic color of the tooth. It's in between that and the over-counter preparations, which in certain countries they're sold over the counter alongside toothpaste, mouth rinses and chewing gum, which merely whiten the teeth by using the removal of extrinsic stain or preventing that from building up. So what are the advantages of the various systems or the various forms of bleaching that we have? Well, home bleaching is less, you tend to get less intense tooth sensitivity, and it can be more effective than power bleaching, especially with the 6% hydrogen peroxide that we're able to use in Europe. The power bleaching or in-surgery bleaching that there is, you get a much quicker response because it's usually about an hour and a half in the chair. You don't have any problems with ingestion of gels because the dentist controls everything and makes sure, and he has to make sure that nothing is ingested because these are usually on higher concentrations of product. Over the counter, it is less expensive. There's no dentist visits involved. However, when we look at the disadvantages of the over-the-counter preparations, they're really generally not really that effective. They tend to have higher concentrations. They can cause tooth damage because some of these products are not really products that we would recommend that you use on teeth, and especially on teeth that have not been checked out by a dentist. On the other hand, what's the disadvantage of home whitening? Well, it can be unpredictable sometimes. It can take weeks. If you don't diagnose the discoloration correctly, then it can take a lot longer than it should. So that's something that is a disadvantage. Power bleaching, you can have greater sensitivity or even a burning of the edges of the necks of the teeth if the procedure is not done properly. You can also get more rapid regression of the shade as a result of the dehydration effect that you tend to get with power bleaching or in-surgery bleaching systems. Now, just a quick word on whitening toothpaste. There are a number of different whitening toothpaste out there. They all work on the principle of stain removal or stain prevention. They can be abrasive in nature, so they have things like hydrated silica and sodium bicarbonate and some, or they can actually have a chemical effect, which actually causes the stain removal chemically or by using enzymes or things like that. Or the newer generations, they actually have an optical effect. The optical effect is, it's again silica based, but it contains things like glucosamine, which is basically a product that is plastered along the tooth surface, and it reflects more light and it gives you the optical illusion of a blue whiteness to the teeth. So that's something that's been around for a little while, but it's relatively new in terms of toothpaste. But do they change the intrinsic color of the tooth, the internal color? No, they don't. So they have a stain removal or stain prevention effect rather than a whitening effect, as in a bleaching effect. When do we think about bleaching? What are the indications? Obviously, general staining, fluorosis, things like calcific metamorphosis. This is when you have a trauma to a tooth that doesn't die and it becomes sclerosed from within and it obliterates the pulp chamber. There are internalized stains that you can whiten. Tetracycline is another case. Aging is the most popular reason why people whiten their teeth, and it's the most successful form of whitening for teeth that have aged. We can whiten them. Smoking and dietary stains are obviously another one, and traumatic pulpal changes. Because this lecture is very, very short, normally it's a one-day lecture, I can't go into all these various causes of discoloration that can be whitened, but I will also just mention very quickly whitening or bleaching procedure pre and post restorative treatment. So you're thinking before you're restoring somebody's mouth with perhaps veneers or lots of fillings and things like this, or crowns, you want to whiten the teeth or bleach the teeth to make them look lighter. But sometimes you have to do it after that you've done restorative treatment or after restorative treatment is being done. So for instance, in this case, this gentleman came to me a number of years ago and he had some crowns that were done that matched his front teeth, but suddenly he said to me, why my teeth have gone dark over the years, can I do anything about it? So what we then did is we then bleached the back of these teeth here, the back teeth, to try to match the crowns at the front and the bridgework at the front. Incidentally, unfortunately, this gentleman has come in about a month ago. He'd had an accident and all those teeth are now gone, and we are doing some implants to the guy. So, but before we actually restore those implants, you can bet that we will be doing some pre-restorative whitening and bleaching of those teeth to get them back to the best level of whiteness that we can. So I've mentioned indications for bleaching. Now let's look at contraindications. There's a very long list there, but if I say to you that the single most important thing on the list is a patient with high expectations. A patient with high expectations is that sort of patient that is demanding that Hollywood smile, that unreasonable type of whiteness that is not always affordable to a patient depending on what their mouth is like. Again, we're not going to go into details in terms of what sort of whiteness we can get to, but I normally call these patients the patients that like a toilet white bowl smile, i.e. they look like toilet tombstones across the whole mouth, and you can't even see the teeth between them. They're looking at people like, I'm not sure if you get somebody like Simon Cowell that's on our screens in Britain, but he's got that sort of smile where it's all veneers and they all look exactly the same. Every time I go into a toilet, I actually instantly remember him actually, but that's not really a good thing to remember somebody by, but that's what happens because of his teeth. So these sort of patients are the sort of patients that have high expectations. Whitening is not going to be for them. Bleaching is not going to be for them. If you practice that sort of dentistry and you want to produce those sort of veneers or lumineers, then it's something that you should consider. But these patients, stay well away from them because they are psychologically never going to be satisfied unless they get that appearance. And if they don't get that appearance, they might well be dissatisfied with what you've done for them, and then even though you might have done a very nice job of whitening their teeth. Okay, so the other contraindications that we can look at are things like decay and periapical lesions. Well, they're contraindications until you actually deal with the decay and you deal with periapical lesions, then you can go ahead and whiten teeth. Patients that can't tolerate the taste of the bleaching gel, that's really more of an indication of doing an in-surgery procedure whereby they're not going to taste it. People that have pre-existing conditions like crowns and things. Now, you saw the previous slide, that person did have crowns and bridges. That's not a contraindication because the original shade of his crowns are lighter than his teeth. But if the teeth are matching, or if the crowns are matching his natural teeth, or they're actually a little bit darker than his natural teeth, then obviously bleaching the teeth, the natural teeth, is a contraindication in this case. If patients have major cracks or exposed dentine, you have to deal with these things. If they've got pre-existing problems with sensitivity, you have to deal with these things before moving on to do any bleaching procedure. Patients that have highly translucent teeth, if you whiten these teeth, they can look darker as a result. And again, I can't go into details how to test these patients out, but trust me, if they've got highly translucent teeth, just be very, very careful before you consider bleaching their teeth. Pregnancy, there's no evidence to suggest there is anything dangerous about whitening during pregnancy. But like anything in Britain, we tend to not do anything for a pregnant or a mother until after she's had the baby. So general dentistry is reduced to a minimum during that time. Now, for this, the last thing here that I've got on this slide is bleaching may make pregnancy gingivitis worse. The people that stay awake for the end of this lecture will then say to me, why is that? And I'll go back to that later on. So the bleaching options that we have in terms of vital bleaching or non-vital bleaching. Vital bleaching is anything for teeth that are not dead, basically, and it's divided into home, in surgery, and over the counter that we've already mentioned. The non-vital, you have a walking bleach technique. Originally, the product was sodium perborate, then it moved on to hydrogen peroxide and sodium perborate. Then nowadays, we just use carbamide peroxide as the product. There is another procedure called the inside-outside technique, which I'll cover later on. And there's also an in-surgery procedure, which I'll cover later on in the lecture. So what are the bleaching side effects? Well, we can get gingival irritation. We can get soft tissue irritation. Altered taste is also something that you can get in terms of after the mouth dries out, like I'm drying out in a minute, I'm going to have to take some water. It can give you an altered taste to your mouth as a result of wearing these trays overnight. Thermal sensitivity is the single most important side effect, and that's something that we'll concentrate a little bit more on later on. Chemical burns is really only for products that are 35% hydrogen peroxide and more. So if you use that for in-surgery bleaching, you have to protect the gums really, really well. I'm not really convinced by external root resorption at all or damage to restorations, but in the literature you will see that, so I've included it in this slide. Now, what are the forms of in-surgery whitening that we have? We have in-surgery or power whitening. Is basically, it can be chemically activated, it can be activated using a curing light, plasma arc lamps, xenon halogen, metal halides, diode lasers. You've also seen the zoom lights. There's all sorts of different ones. You can activate these form of whitening in this way. It does not mean that these are the products that are actually making it sort of whitening. It's just merely an activation. The actual product itself is what actually causes the whiteness or the bleaching of the teeth. Now, there is a waiting room technique where you can use a higher concentration of carbamide peroxide, or you can use a combination. And the combination, I think Tanya's already mentioned, the power whitening beforehand and then a home top-up. There are companies here in Britain that advocate or used to advocate. What they used to do is do home whitening and then they go and do power whitening. Their idea is it makes the teeth, opens up the pores of the teeth, and then for the power whitening to work better. That is not really correct, because whitening per se, bleaching using the good products that we're advocating, such as Polar, office products and stuff does not actually cause any increase in the pore sizes of the teeth. It does not cause damage in that way. So that is actually technically incorrect. Okay, so what are the advantages and disadvantages of in-surgery or power whitening or power bleaching? The advantages is really the single most important advantage is patients accept it. There is no problem with tray tolerance or gagging or any taste problems. Generally, it takes less time. You get the overall effects much quicker. Even if you have to do it more than once, the effects are a lot quicker. So an hour and a half in the chair, even if you did it 3 times, you can finish the procedure a lot quicker than home whitening. The other important thing for it actually is I find that it motivates the patient to see a result immediately. You think, okay, and I turn around to the patient and say, look, we've got to here, but I really do believe you can get better than this. So by this time, I would have already made them the whitening trays, and then I just send them home with a top up for them to top up for the next week or so, and they come back with a really nice combination results that that is really good for them. The disadvantages of power whitening is there's increased surgery time. You can take more than once. It can need more than one session. The cost of retreatment is exactly the same, whereas in home whitening, if you're going to retreat a top-up treatment, you just need basically to keep the trays and you just give them some more syringes. You also have the added disadvantage of a dehydration and the regression of shade. So usually what happens with especially the higher concentration products is they tend to overshoot the results and then they fade back over the next 24, 48 hours when the teeth rehydrate. But as long as you've managed your patient's expectations correctly, it's not a problem. And to be fair, products such as Polar Office have a lot of water content in their product, and that's reduced the effect of the regression of the shade and dehydration. So I'm going to quickly talk about Polar Office Plus. You probably might have Polar Office, which is 35 or 37% hydrogen peroxide. In fact, I think it's 37.5% hydrogen peroxide. It equally has a high pH activation. It has a great release of the peroxide, release of peroxide ions. It has a very good handling property in terms of being able to spread it across the teeth nicely, and you can use it with or without the light. I will tell you from my own perspective, patients like to see a light. So it's a good idea to use the light, even though you know that it actually is not adding a huge amount to the procedure. And I don't have time to explain why that is. Now, it has, I'm not sure about the pH of the product that you have, but I would say it would be high pH, so that reduces the sensitivity usually. It is, again, it's a very stable product because usually the 2 parts of the syringe are kept apart so that until it's activated, it doesn't degrade. Once it's activated, it starts to degrade. And it usually has a built-in desensitizer, which is usually potassium nitrate and fluoride, which is very good in terms of desensitizing the teeth. And we'll talk about sensitivity later on. So for products such as power whitening, power bleaching, you must, especially if you're using 37% hydrogen peroxide, you must isolate the teeth, and you isolate the teeth by using a paint-on dam. You can use rubber dam and caulking putty underneath it, but usually I like to isolate with paint-on dam. This is an old slide. You will see if we were to do it now, we would be using a lot more paint-on, and we would also have cotton gauze around it. So basically no mucosa, or as the Americans say, no pink can be seen. And even the lips are covered up as well. So it really protects. And you put the gel on the teeth, and then if you're going to activate with a light, you activate for a light. In terms of hydrogen peroxide, in terms of Polar Office, it's up to 10-15 minutes for a bleaching pass. Then you take it off, then you do another 10-15 minutes, and then you take it off, and then you do it again. Now, if you're using higher concentration, i.e. 37.5%, it's usually my time is 10%, whereas when I'm doing 6% hydrogen peroxide, I'm doing 10-15 minutes. I'm doing more towards 15 minutes. Okay, so there is a reason, because the hydroxyls that actually break down from the product and go into, they can penetrate towards the nerve within about 15 minutes. That doesn't mean to say they're going to cause pulpitis or anything like that, but it means they're picked up during that time. So what you do is stopping that diffusion gradient during that time. After 15 minutes, you take it off. But if you're using 37.5%, I would definitely say about 10%, 10 minutes at a time. And in fact, I have a feeling the polar team advise 8 minutes, although I do 10 minutes, but that's because from my research, I'm happy to do 10 minutes per bleaching pass. So you can activate it in a number of ways. This is a Lumarach light from years ago. This is a laser, and again, you can use the actually the polar have a very nice light called the Radii Plus. I think, I'm not sure what Plus or Pro 2 or they've got a number of new lights, and they have a special whitening attachment that goes with it. It fits really neatly either onto your chair or on a stand, and actually patients tend to like to see that, and it tends to work quite well with this system. So you can see you can really overshoot the whitening effect straight after whitening. That will dull down. You'll see that's a pre-op, and that's straight after whitening. It will dull down over the next 48 hours. That's quite normal. But it still look white, but obviously not as white as that. This is a case of a young lady who actually came out to South Africa to live. This is years ago. She had tetracycline staining. She wanted to do whitening. I said to her, look, tetracycline is going to take you months, really. She wanted a quick effect because she was getting married. So I said to her, any tetracycline or anything like that, up to the area where the tetracycline staining is, the tooth will behave normally. So whitening that area using an in-surgery procedure will whiten straight away that area, but it's the rest of it that she needed to go home and do some more with, and that's what she did. Unfortunately, I haven't seen her back since she went to South Africa. She got married and obviously is happily living out there. So I can't tell you what the final results of this is, but it will tend to work very, very quickly on the areas that are not tetracycline stained, but the areas that are tetracycline stained, you will really need overnight bleaching for a number of months, from anywhere, depending on the severity, from 2 months to up to 6 months to even 10 months or even longer for the really heavily stained tetracycline cases. This is another one of my first tetracycline cases that I ever did. Again, this was using laser whitening, and in this case, the advantage of this is the tetracycline staining is more incisal. It's better to be incisal stained rather than gingival. Gingival is a lot more difficult and will take a lot longer, but the incisal will actually work even with whitening of a one session. You can see there's been an improvement, but you would need more than one session. And in this case, actually, I sent this chap off to have whitening with trays to continue with it. And with cases like this, you can probably confidently say if the tetracycline staining is in that region, it will eventually disappear, all of it. Whereas that sort of tetracycline staining in the neck of the tooth will be a lot more difficult. So let's look at home whitening or home bleaching. The advantage of this is it's a really simple and fast procedure to use. You don't really need much of a clinical time. It's very simple to monitor. It should be at a lot lower cost to the patient. And patients bleach at their own pace. And usually, whitening is within days. For your average patient, within the first 1 to 4 days, most of their whitening would have occurred. Okay? The rest of it is when it starts to plateau off, and it takes a lot, anywhere between 2 to 6 weeks. But you will notice whitening effects very, very, very quickly, even with home whitening. The disadvantage used to be that there was a problem with patient participation and compliance. The color change depended on the wear of these trays, and some patients used to retch, and excessive use can cause an abuse of this thing, and they can do this procedure. But really, in the modern day modern day patients, really it's not much of an advantage because the compliance is pretty good. People have been watching these smile makeovers, they've been doing all sorts of things, and they really want something to happen. Once they see something's happening, they will continue quite happily, as long as you can control any side effects that they may have, such as sensitivity. Okay, let me show you this case. This young lady came to us and she had a number of different colored teeth here. The central incisor was discolored. Again, she'd had some sort of trauma to it, but the tooth was actually still alive. So she had calcific metamorphosis again. The canine teeth are always darker than the rest of the mouth. So what you do in the cases like this is you basically start to whiten those teeth, the darkest teeth first. Once these go lighter, then you start to darken, you start to whiten the rest of it. So in this case here, we started to whiten, and you can see that at the end, it's not totally disappeared, but we only got to start whitening the rest of the mouth once this tooth started to shift. So it makes it easier so that if that tooth doesn't shift, then you're not going to make the rest of the teeth really light compared to that one. So you are controlling your risks. In most cases, if you've done your if you've actually diagnosed your discoloration correctly, you can forecast how much whitening will take place. Now, in this case, this gentleman, this is before whitening, this is after whitening. Now, you might think, what have I done to this tooth? Well, actually, I've done nothing to this tooth. This is a crown that this patient, sorry, my screen is going by itself now. This is a crown that is going, that the patient wanted to replace anyway after whitening. So what we did, this is the greatest example of showing a patient how much whitening has taken place, is to leave the crown in place, do the whitening, and then change the crown afterwards. So you'll see you can get some pretty dramatic effects with this. If the tooth didn't match beforehand, if it was like this in the first place here, and then you started to whiten the teeth, that would be a disaster. So you know, you'd have to replace the crown. The patient needs to be aware of this. I hope everybody can still hear me, because I keep hearing popping noises and I'm not really sure if there's a problem, but I hope that everybody can hear. Okay, so home whitening, as I said to you, or home bleaching, there is a range of 5 to 16% carbon peroxide. You can use that during the day, or you can use that at night, or up to 6% day wear, which is hydrogen peroxide. Forget these different types of trays that I'm talking about here, because they're based on soft trays, and I'm going to show you exactly my tray design that I've been using for a long, long time, and it's tried and tested, and it works. It works really, really well. But the normal regimen for home bleaching is overnight use, or 2 to 4 hours per day for up to 6 weeks for normal patients, or 2 to 4 months or even longer for tetracycline patients. Now, some people like to do single arch bleaching, and some people like to do double. I personally like to do double arch bleaching because it's a quicker procedure, there's less of a problem with compliance, and there's less surgery time involved, less reviews, and it's a reduced cost to the patient. If you have a patient that's not convinced, I don't get these patients anymore, but I used to. In those cases, what we used to do is we used to just whiten one set so they can see what the difference is, and then they can continue. This idea of it has a reduced impact on occlusion, that's not really that much of an issue anymore, because years ago we used to use much thicker bleaching trays. We don't use that anymore. And this whole idea of a reduced sensitivity because less teeth are treated, yes, but in my experience, usually one arch will have sensitivity rather than double arches that have sensitivity. So I would prefer to do double arch bleaching, but it is up to you to decide for your particular patient. Okay, so what I actually use is both of these products. The Polar Day is 6% hydrogen peroxide. There are lower concentrations of this product around, but I tend to use 6% hydrogen peroxide. And again, I tend to use it slightly longer than the manufacturer says. SDI will say to you up to 45 minutes. I actually recommend up to an hour and a half. The reason I say for hydrogen peroxide to do that is because the effects of that, the half-life of that is it will reduce the grade to about 50% within half an hour anyway. So by going to about an hour and a half, you're not really causing yourself too much issues. Whereas Polar Night, my go-to percentage that I go to is the gold standard is 10% carbon peroxide. For some patients, I will use 16%, but most of the time I'll go for 10% overnight bleaching. It's my favorite way of doing things, and it's the most secure way of doing things, and it's the most researched form of tooth whitening or bleaching. So another case here to show you, again, this tooth, the patient had trauma to this tooth, is slightly darker than the rest of the mouth. This is years ago, we did a scallop tray. We pointed to the patient which tooth he's going to have to whiten first. He starts to whiten it. Once he whitens that tooth, then we continue and whiten the rest of the mouth. And as you can see, you can get really, really nice results just using home whitening, and it doesn't take long. Another interesting case is this lady who came 6 weeks before her wedding, said to me, I need to have my teeth whitened or something done with the upper left 1, 2, 3. Well, again, we checked these teeth out. She had a trauma on a bicycle when she was young. Unfortunately for her, none of those teeth died. She also tends to have a habit of over scrubbing, but since the pulp chamber of that tooth is obliterated, she will have no issues with sensitivity with whitening, with bleaching in this case. So what we did is we just purely whitened these teeth by themselves and then continued with trying to restore the rest of the mouth. And what we did is, you can see that is started to go, and then we actually restored the rest of the mouth to conform to a nicer smile. We even put some composites across the she's a bruxist, so we put some composites across the incisal edges to make the effect look a little bit nicer. And I think you'll agree, she can at least smile for her wedding a little bit better than she would have done with the what she came in with. Now, if you're going to take away anything from me today, please look at this tray design, and I'll explain to you why this tray design is good and why I've been using it. Basically, the border is very important. If you have a double border on these trays, you make the product less susceptible to saliva. Saliva has peroxidase, an enzyme that will break down the product, and just general dilution of the product will mean less of an effect. So by doing this border design, you'll actually increase the effectiveness of your whitening procedure, bleaching procedure. There is absolutely no need to do any reservoirs. It is generally accepted now that reservoirs are not needed. The only time I'll ever use a reservoir is for certain patients that have they're slightly sort of delicate patients that have teeth that are or gums that are friable, and they're a little bit sort of anxious. Even by wearing a tray can cause, without anything inside it, can cause some sensitivity for these patients. So by putting a reservoir on there actually means that there's less pinching effect on their teeth and hence less sensitivity. But I don't remember doing a reservoir for over 15 years. So that to give you an idea of how much a reservoir is needed. So if you look at this model, you will see what we do is we cut round with a round burr all around the neck of the teeth into the sulcus, between the gingival sulcus and the tooth, with say a round diamond or something like that, and you go all the way around, almost like cutting a post dam on a denture, the palatal aspect of the denture. If you do that really well, you then make the tray, and the tray then, suck down splint of the tray, you're using a 1mm soft tray, or I'm tending to use a semi-hard rather than a soft tray to make it a little bit less deformed. The tray, when you make it with just soft material by itself, it tends to sort of warp a little bit more. When you're using semi-hard material, it's better, but you still keep it thin. And what you do is you have an interior border and an exterior border, so that seals nicely, so that when you're telling the patients to put the product on, you're only actually filling the product to about there, about a third, and then you get the patient to actually push down on the teeth and spread the product across the whole of the teeth. You'll notice that no product will come out from here because it's got one border there and one border there. The fact that you haven't got an extended border and in fact you can use a very minimal amount of bleaching agent will also have an impact on reducing the sensitivity that the patient feels. And so it's a really, really good, easy design that you can do. In fact, in my practice, we make our own trays, but you can get your technician to do that for you. So let's look at tooth sensitivity. Tooth sensitivity tends to be either chemical, i.e. it's reversible pulpitis, or it can be just purely by mechanical tray pressure. As I said to you, I think one study showed that 18% of people in that study had sensitivity by just wearing a tray without having any bleaching agent inside. So that causes an issue for some people. So gingival irritation, it can be mechanical tray pressure, i.e. if the tray's overextended, you can cause gingival irritation, or you can get gingival irritation or sensitivity of the gums as a result of putting too much bleaching agent on there. So by using that tray design that I said earlier, it actually means that you really shouldn't have any issues with irritation of the gums whatsoever. So what do you do if you weren't using these tray designs? When you actually check these tray designs, you check and see, you make sure that really I'm just going to go back 1 minute. The tray does really not extend any more than about a millimeter above the free gingival margin. It really doesn't need to be anything more than that. That's as much as you can go, as you need to go. And then if that was the case, you should reduce it and cut it back and polish it back. If the patient is putting too much stuff and it's coming through, again, that's an issue. Or if the patient goes away with this sort of design and they still have problems, then you should consider some sort of a reservoir. But as I say, in my experience, I haven't had to use a reservoir for absolutely years and years and years. I don't think you would need to. So how do we control tooth sensitivity? This sensitivity, what I'm talking about is when the patients have something hot or cold, they go, "Oh, that hurts," and that happens usually in the first 4 days of tooth whitening if you're doing home whitening, or it happens sort of 24, 48 hours after in-surgery whitening. They're treated differently. I'm talking about here home whitening and how we're going to deal with that, or home bleaching. You can do it passively by reducing the wearing times. So if the patient is bleaching every night, what you do is you don't bleach every night, you bleach every other night. So you reduce the frequency while they're wearing these trays. If that doesn't work, you can actually stop bleaching for a while and then go back to it. Or you can do a combination. A combination, what I tend to do is to actually actively treat the sensitivity by either getting the patient to use neutral fluoride gels, or better still, using 3 to 5% potassium nitrate gels. And we'll talk a little bit about those in just a minute. Where we get these is you can either supply them to your patients. So there are products such as Soothe from SDI, which is a 5%, or it could be a 6%. I always have a memory lapse when it comes to this. I think it's 5% potassium nitrate. You can use other products like Tooth Mousse or Relief, whatever you want to use. But I tend to use Soothe because it's a product that I know very well. And it's a syringe that comes just like a whitening syringe, and they can put it inside the trays and they can use it for half an hour after whitening. Or they can do it beforehand. It depends on the situation. Or if you have patients such as that we have in Britain, whereby we have a lot of samples from Sensodyne Pro Enamel, Colgate Pro Relief, things like that. We tend to give them those, and they can actually just rub onto the area where it's sensitive, or if it's more general sensitivity, they can put inside the tray and actually use it as a desensitizing carrier for the whitening. Now, what I tend to do though is I tend to sort of get the patients to have an initial hygiene visit and take impressions. If they've had no sensitivity at all, and there are no exam indicators, I mean, there's no sensitivity at the buccal, sort of any areas of recession, or there's no sensitivity for moving a probe across the necks of the teeth, then I'll just do a normal bleaching regimen. And then if they experience sensitivity, then I'll move on to passive treatment or active treatment, or a combination of both. If they have previous sensitivity, or during my examination I find that they've got a little sensitive spot, or there is a bit of an area where I'm just probing and there's a little bit of sensitivity, I will immediately get them to use a desensitizing toothpaste for 2 weeks before I whiten the teeth, with a desensitizing toothpaste, as I mentioned earlier. Then I treat them as normal, and then start to treat them like in terms of passive or with active or passive treatment, rather than just go full speed ahead with the whitening procedure. Again, there's a number of different ways of dealing with this, but my lecture is too short today to actually go into details with how we treat various cases. I'll move on very quickly to non-vital bleaching, so I'm very conscious of the time. Non-vital bleaching. Now, the important thing with non-vital bleaching is to seal the apex of the access to the apex of the tooth. It is very, very important that you think about once you open up the pulp chamber, you need to clean it out. You need to remove the pulp holes. You need to clean it out with all the products that's inside it. Any dead tissues, i.e. Blood products, any medicaments. If you do endodontics like I do endodontics and you've got the sealer all over the place, that's not a good thing. You need to really remove it, and I tend to use an ultrasonic inside the whole of the pulp chamber and clean it really out. Then what you must do is you must protect the pulp chamber. Now, I protect the pulp chamber by actually cleaning out some of the GP point up to about 3 millimeters beyond the cemento enamel junction, so that I'm above the crestal bone level. Then I will place a radio opaque glass ionomer, something like Riva Self Cure glass ionomer or Riva Light Cure glass ionomer, and then I will seal it at that level. I will try not to get onto the actual the crown, the inside of the crown of the tooth, because if you do, you are then liable not to be bleaching the neck discoloration around the cemento enamel junction. So you need to. That's why one of the reasons why you need to protect the pulp, the root canal filling, but you need to protect it above the crestal bone level to make sure that your dental tubules that lead out above the cemento enamel junction are protected to they're open to the whitening product rather than below the cemento enamel junction where you want to seal them and prevent the product from going into the periodontal ligament. Once you've done that, you would then put your bleaching product inside there, you seal it up, the patient will go away and then come back, and then you redo the process until the patient is happy with the tooth discoloration is removed. When we talk about inside-outside bleaching, we talk about a number of different techniques. The whole idea of inside-outside is you've got access to the inside of the cavity and the outside of the cavity. And the open technique basically means you actually do the same preparation as any walking bleach technique that we did earlier. That's the walking bleach technique that we talked about earlier. You do exactly the same preparation, except what you've made a tray, and you are now going to be putting the product inside the pulp chamber and outside at the same time. That's the open tray technique that you would use for inside-outside bleaching. You can imagine you are bleaching from inside and outside. There are advantages to that. You get the process done a lot quicker. Another technique that we have available is the inside-outside technique, but the closed technique, which is basically like the walking bleach technique, which is exactly the same as we said earlier, but you also have a bleaching tray and you're doing it from the outside at the same time. So you've got this closed technique. The first technique that we mentioned here is a bit more difficult for patients that are that manual dexterity is not good enough. This technique is much more difficult, and we really reserve it for people that have very good technique in terms of manual dexterity. They're able to put the product inside there. This has the advantage, it's the quickest because patients can replace that overnight. Some people can do it during the day. There's also something called the modified inside-outside bleaching approach, whereby you're replacing this product every 2 to 4 hours. So there are a number of different a number of different approaches you can have. But generally, we tend to find that patients that tend to do this need to be really on the ball with their dexterity to be able to do that. A lot of patients can do this because you're doing the hard work for them. The rest of it is just the tray. Again, you'd equally get results much quicker than if you just did the product, the walking bleach by itself. But that's the inside-outside closed technique. This is another technique that we used years ago. Please ignore these crowns and stuff. This is not mine, and this is an old lady that wasn't interested in doing anything except I had to do everything. So this is in the days where you can use higher concentration products. You clean out the tooth, you clean out the cavity, you prepare it as normal, then you're putting inside and outside a higher concentration of hydrogen peroxide. So in this case, it was 35% hydrogen peroxide. We put on the teeth for about 5 minutes each time, then you take it off. And I think at the time we activated with the laser, but you can get a very, very good satisfactory result very, very quickly with this sort of technique. But what you mustn't do is you mustn't actually close up that cavity straight away on the same visit. because if you do, that bond is not going to be good enough in terms of composite. But you can use glass Sulieman for that as an initial close-up, and then a few weeks later, when all the bleaching products have dissipated from the mouth, from the tooth, then you can go back and get a good, an exact, a normal bond with composites after bleaching. This is another case where a bit of trauma. You can see quite easily that the tooth is quite dark. The patient wasn't interested in doing anything else apart from this, so you would have to cut out your bleaching trace from the other teeth so that you don't whiten the other teeth, you only whiten that tooth, and you can get some pretty nice results as a result of using this approach. Okay, let's move on. This is a lady that had orthodontics, and as you all know, orthodontics, if you move the teeth too quickly, teeth can die. So the orthodontist very kindly said to me, could you please do the root treatment for this lady? And could you please whiten her teeth? So what we did is we did the root treatment for this lady, and over a weekend, using her own Essex retainers, we managed to do inside-outside whitening. And even though the whitening, just so you're aware that her Essex retainers will only go up to here, they don't go all the way up, yet the inside-outside approach will still work very well on such cases. Now, years and years gone by, this lady came in. She was going to have some veneers done, and she said to me, I want my teeth veneered. And I said, okay, fine. So I said to her, I'd like to whiten her tooth first. She looked at me, and you can tell how old this is because this is the old foam back tray technique that we used to use. It was foam back so that you could put the product inside, and you can see clearly that we've removed the bleach from other teeth that don't need to be bleached, and we just did that tooth. You might think, well, why the hell are you bleaching this tooth if you're going to veneer it? The reason for this is you reduce the amount of tooth substance by whitening the tooth in the first hand. You actually become more conservative in your approach in terms of restoring. Quite often, if a patient didn't have something like this where she had existing veneers that have gone wrong here, I would actually whiten the teeth regardless. If they're quite heavily stained, if I whiten the teeth, quite often patients will be happy without actually having veneers. But if they're not happy, then it means I cut less of the tooth off to actually mask the effects of the discoloration. Now you might say, well, if you're doing the sort of toilet wipe veneers that you're talking about before, you don't need to do that. But obviously I don't do that sort of toilet wipe veneers. I do sort of more natural looking veneers, and hence that's why I would whiten teeth beforehand. So we've mentioned over-the-counter preparations. There are strips, wraps, stock trays, paint-on stuff, all sorts of different products out there. Why would I not like the idea of over-the-counter? Well, there's no diagnosis of the tooth discoloration whatsoever. If there's any dental decay or any disease or internal resorption, nobody's going to know. And that person can end up having a whopping great big abscess without, anything. If they've got existing crowns and restorations, they're not going to know. They're going to mismatch, they're going to cause themselves problems. The fit of the tray, if they are making these boil and bite trays, really, they're not that great. And how do they know what products they're getting? From the internet, they're getting all sorts of rubbish that are actually quite bad. And some of these products actually release chlorine gas in the mouth, which is totally dangerous. So I don't really like over-the-counter preparations per se. However, there are products that are out there that they've used in the past. So this chappie here used white strips years ago, and nowadays we also have, this lady also has used, I think we used Polar Paint on here, Polar Illuminate on there. This is a product that is 6% hydrogen peroxide. It's actually painted on the teeth. So the whole idea is they move the lips out of the way, they dry the teeth, they paint on this product, it sort of quickly dries, and it's helped to recharge the brightness. So in this case, I think this lady was probably had whitening done before, and then we had to energize her whiteness, and she used that product to make her teeth white again. It works very, very well for patients. The 6% hydrogen peroxide, Polar Illuminate, and things like white strips, which is like a product that you can put on the teeth. They actually use hydrogen peroxide, so we know that that product works. The only difference between them and a tray you have a much better control, much better fit, and you're not relying on the patient. Even if some of my patients don't want me to whiten their teeth, I would still rather do a diagnosis and actually tell them what will work for them. And then if they want to go ahead and use white strips or they use Polar Illuminate, I have no issues with that. But at least I've protected them from doing some damage to the teeth of their dentition in the first place. So I think I've already mentioned this, the product. I've come to the final, I think I'm going to overrun, so excuse me, because it's very difficult to judge. There's a lot of information out here that I needed to give, so excuse me for running slightly over. We are now using, so why did I call the lecture Whitening Paradigm? Well, because actually we're using whitening trays in different ways to therapeutically work in other areas of dentistry, not just cosmetics. Because carbamide peroxide is an anti-plaque agent, and I said to you, anybody who's awake at the end will ask me, why did I say carbamide peroxide or whitening may make bleaching, may make pregnancy gingivitis worse? It's an anti-plaque agent, and technically it shouldn't make gingivitis worse. It would actually make it better. But with pregnancy gingivitis, there's a slightly different etiology, and the actual presence of the trace make the situation worse. Whereas in reality, using carbamide peroxide is an anti-plaque agent, and it will make the situation with the gums much better, as we'll mention in a minute. We're also using fluoride in these trays to actually desensitize teeth, to treat things like remineralization and caries prevention. We're also using it to treat dentine hypersensitivity. We're also using things like potassium nitrate, i.e. Things like Soothe, to help in desensitizing people's teeth as well. There are other products, acidylated calcium phosphate, again, is being used for sensitivity and dentine hypersensitivity, and this so-called caries reversal, whereby it precipitates into the enamel defects and hydrolyzes to form hydroxyapatite. So there are therapeutic uses to these trays, these whitening trays. We're using them for the elderly patients, for special care dentistry, for orthodontics, caries controls, as I mentioned, gingival health, and sensitivity control. So it opens up a brand new field of use of these whitening products, not just for whitening people's teeth or bleaching people's teeth. So for the elderly patients, they have reduced manual dexterity, they have decreased oral hygiene and increased part levels. We can use things like carbamide peroxide, especially for patients that have, say, root caries and are heavily restored mouths that are at increased risk, that we can use that very, very effectively in controlling this, the progression of caries. Special care dentistry for people that have xerostomia, for people that have compromised immune systems. They are people that have reduced dexterity or physical challenges. Again, this product will work very, very well to enhance the health of their teeth and gums. Orthodontic patients, quite often, in fact, bleaching was discovered as a result of hydrogen peroxide or carbamide peroxide, in fact, hydrogen peroxide being used in injury after sort of orthodontics. And Klusmeyer, all those years ago, according to Professor Van Hayward, in '89, when he first described the nighttime home bleaching technique, described the product being used for orthodontic cases in terms of mouth injury, whereas we actually now use it routinely to actually control during orthodontics for people that have sort of a lot of plaque retention. We can use trays. You can even use it for people that are using things like Invisalign. In fact, quite often I use it in Invisalign cases, especially at the end of Invisalign, to actually whiten people's teeth. But in terms of if they're at increased risk of caries or they have periodontal issues, carbamide peroxide, 10% carbamide peroxide works very, very well for these patients. So in terms of caries, why does it work? Because it increases the plaque pH to over 8, and you know that with that, you've got, with increased salivary flow, you're going to at least for 2 hours after this application, you're going to reverse the caries process because it can't take place during in that sort of pH. Incidentally, hydroxyl free radicals that are released in surgery bleaching are actually bactericidal. They will kill off bacteria as well. So that is also an added benefit for the hygiene, the bleaching agents. In terms of the gingival health, we've noted in a reduction in probing depths, in plaque levels, and gingival indices per se as a result of using carbamide peroxide. So I will tend to actually favor using, for any patient that I'm doing, say, root scale debridement on, and there are continuing perio cases, I'll actually offer them carbamide peroxide overnight, not only to whiten their teeth and give them some sort of effect that will make them feel a bit better about their teeth, but also actually it increases the oxygen, thereby promoting the healing effects and improving gingivitis scores with this, as well as being bactericidal and actually dislodging. It has a dislodging effect on the biofilm in there. And if you think about it, because it's going for over 10 hours, you can use it if somebody sleeps for that long. You've got a continued effect of this product, keeps going for the patient. Finally, my final slide. I hope I'm nearly exactly on time. I like to call this the cosmetic wheel of dentistry, whereby we have tooth whitening at the center of everything. I already mentioned Invisalign. Invisalign is a really big thing for us nowadays, and nearly every patient, in fact, every patient I do Invisalign treatment on, I will use tooth whitening. There are patients that will come in for veneers. I said I'll do tooth whitening on. Any patients that I've already mentioned, the patient with implants, I'll do tooth whitening beforehand, before crowns. And generally, years ago, it was just tooth discoloration where we used tooth whitening. Whereas now, you have patients that want to change, they sort of want to change the shape of their teeth and doing some edge bonding, and then would volunteer some whitening beforehand. So it can be really a central cog in the wheel of cosmetic dentistry, tooth whitening. And I hope I've kept you awake at least, and if you've got any more questions, by all means, please ask me now. And thank you for listening, and I hope most of you are still there, even though I doubt it, because it's been a long lecture. Thank you. I'll hand over now back to Tanya to take over.
Perfect. Thank you very much, Dr. Munther. There's one question on the chat side here. The temp material for internal bleach. Seal off, question mark.
What was the question?
Temp material. What temp material are you using for your internal bleach to seal off?
You can use whatever you like. Normally, I like to use the simplest form of temporary material. So something like Coltisol or something like that. Basically, something that just seals over. Because you're going to open it up, you want something simple. If you use things like glass cyanamers, you can do. It means drilling it off and stuff. I tend to use this sort of product because I can just use an ultrasonic to take it off quite easily. But once I'm finished, I will definitely then seal with glass cynamer. Right at the start, once I've sealed with glass cynamer, then I allow the bleaching product to dissipate from the tooth, and then later on I will reduce that down and then put a layer of composite on top.
Okay, then using a high percentage of carbamide peroxide, is it harmful to the teeth?
No, it's not. Depends what you're using. If you're using a product from people like SDI or Ultradent or people like that, it's not harmful. What it is it tends to work a little bit quicker, but it tends to give you more sensitivity. So I'm not sure what percentages you've got available in South Africa. Do you have 22% still out there, or 20%?
Yes.
You do. Okay.
Yes.
So that will work fine. It tends to give you a quicker response, but I do tend to find that you will get a little bit of a fade back with that product, and then but it will still bleach in exactly the same way. It will not cause any damage whatsoever.
Perfect. Then Dr. Shabir Hassan, he's also a whitening guru in South Africa. Current research and Raman Spectroscopy show bleaching is actually a process where hydrogen peroxide absorbs into the tooth and highest concentration at a DEJ. Should we actually rethink our current models on bleaching to this end with model? Do you feel it is most appropriate to explain how bleaching works?
Right. Okay. Yes, there's been Raman spectroscopy bleaching studies for a long time, and the issue with bleaching is, in fact, what we really need to remember is this: the perhydroxyl and free radicals that actually penetrate the pulp chamber can get there very quickly. So the higher the concentration of the product, the quicker it gets there. You can play about with bleaching products, and it's been enforced upon us in Europe, because in Europe we're not allowed to use anything more than 6% hydrogen peroxide. So what we've done in Europe, or what's happened in Europe, we're using all sorts of catalysts and agents to make the produce the free radicals a lot quicker, the breakdown of the product a lot quicker, to penetrate a lot quicker. So from that point of view, I think I tend to agree with him. And to be honest with you, it's highly unlikely that I would ever go back to using the higher concentration stuff, because there are products that work very well. Now, if you ask me, would I actually personally would love to go down the route of home whitening for everybody, but I know it's not feasible for everybody. So home whitening is the safest, and I mentioned, I think in my lecture earlier, 10% is the gold standard, 10% carbamide peroxide, overnight bleaching. It's the most secure way of bleaching somebody's teeth, and you've got more data to back you up than anybody else out there, than any other product out there. So yes, I would tend to agree with that. I don't know what's going to happen here in Europe. I'm not sure what your authorities, perhaps Dr. Shabir can tell us what the thought process is in South Africa, what they're tending to do.
Perfect. Then would desensitizing the sensitive toothpaste 2 weeks before treatment not impact on the bleaching agent ability to work or penetrate the enamel dentine effectively?
No. The simple answer is no. The product, it's the free radicals are so tiny they will get through the micropores. So don't worry about that. And using and even during the process when you're doing whitening, these products have desensitizing agents in them anyway while you're doing it.
Okay, then another question from Dr. Shabir Hassan. The etiology of sensitivity from dental bleaching and buccal root sensitivity is presumably different. So why do we treat them the same?
Right. This is a really big subject. The sensitivity, it's multifactorial. We are not necessarily treating them as the same. What we are doing is we're using different modalities. What I tend to do is I tend to actually utilize a number of different ways. Look, the easiest way, I mentioned this, actually, I probably didn't mention it in my previous lecture. One of the best ways to treat sensitivity, actually, buccal sensitivity, is actually with Revastar. Revastar used well, that will give you a great way of treating sensitivity, because it actually precipitates and blocks the tubules big time. You know, that's the best use of that product. I talked a lot about bactericidal effect and things like that with Revastar. Its original and intended use, especially in Europe, is actually for desensitizing. So from that point of view, you've got other products that will work better. However, it depends on the type of sensitivity you have, and we try different modalities. I agree with him, there are a number of different ways. It's such a big subject. I'm not an expert on dentine hypersensitivity, but I do know when I did my PhD, I was working with my supervisor was Professor Martin Addy, who is a guru of this area, or who's retired now. But there's a lot of different, the etiology is different. We do know that the approach, what works for some people doesn't work for everybody. So you have to sort of mix and match what you can for different people.
Perfect. Then what are your thoughts of in-office bleaching like Zoom?
Zoom is a product that is probably the best known product because it's a big American company. Would I really want to spend thousands of pounds to buy the Zoom Light myself? No, I was given the Zoom Light. Do I use it now? I don't use it. However, what you actually have, and some of the research that I've done on this will back me up, is what you're trying to do is you're trying to activate this product. The light does not whiten teeth. The light merely expediates the breakdown of this product, and it's the free radicals that fizz through that will actually cause the effect. So you can have all sorts of different things that that are used to speed up the process. My only issue with a lot of the light systems is this: you're using higher concentrations per se, and for the reasons we mentioned earlier in terms of how quickly they penetrate into the pulp, you can't keep it on for that long. So by applying more and more free radicals to do the job, you're doing it quicker, but at any one time, those are working at certain chromophore molecules. Once all the sites are taken up, until they break off, it doesn't matter how many free radicals are available. So I don't think it makes a big difference. What makes a big difference is actually time. The longer you can do the whitening for, I think, is the better. And that proves it in terms of even home whitening. One of my papers that I did research years gone by, we compared, and also people like Leonard et al. Years and years ago, I think it was 98, did some research that they did whitening using 16% carbon peroxide, 10% and 5%, and they found they reached the same endpoint. It's just the time that it took to do it was quicker, and that's all it is. So I think time factor is the most important thing rather than the concentration. Yes, there will be some issues in terms of how quickly you get there and stuff like that. But in terms of in surgery, you're not spending that much time doing this to make a big difference in terms of the light systems that they use.
Okay, then does bleaching affect the bonding agents?
Yes, bleaching. Because bleaching is hydrogen peroxide that breaks down into free radicals. One of the free radicals that breaks down is basically an oxygen free radical. And oxygen inhibits the bond. So if any of you used to use Panavia, the adhesive for Maryland bridges and stuff, we used to have a lovely blue gel that we used to put on there to actually stop the inhibition from air on the product. So equally, you'll only get 25% in terms of the bleaching, in terms of the bonding ability if you do it straight after whitening. Whereas if you wait 10 days, 2 weeks, all that product would have come out of the tooth. Then you go back to normal levels of bonding. By the way, I've just seen Michael has put. Michael Farrows is the sales manager for, in fact, he's the European manager for SDI. He's corrected me. It is 6% potassium nitrate for the Sooth product, so not 5% as I thought. I always get it wrong.
Be close. Okay, I can't see any more questions, so I'm just going to share my screen with the little promotions.
Brilliant, and thank you for the messages, especially it's an honor to get another bleaching expert to say they enjoyed my presentation. Thank you, Dr. Sulieman.
I don't know why is it not sharing. Okay, let's try that now. It's just spinning. So I'm going to just read it to you guys. Sorry about that. Hopefully it will catch up as we go. So the Polar Office, you get it in a 3 syringe pack. The syringes are quite large. So when I do Polar in office, I get about 2 patients out of 1 syringe. So on the Polar Office pack that's on promotion tonight, there's 3 syringes in. There's 3 gingival barrier dams in, and you get 3 Optragate mouth retractors. That is going for 1,900 Rand. So out of the kit, you will get minimum about 5 patients in chair whitening system or in chair whitening treatments. And the normal price is 2,564 Rand. And then the polar day, polar night. Doctor, maybe you can also explain the difference between the polar day and polar night. Polar day
is hydrogen peroxide, basically. As I explained earlier, hydrogen peroxide breaks down very quickly. So there's no use using polar day during the night because it will break down, but 50% of the effect of it will be gone within half an hour. So polar day is hydrogen peroxide. Carbamide peroxide, its half-life is 2 to 4 hours. So it'll go down to 50% of its effect after 2 to 4 hours. So it's effective up to 8 hours later. That's why polar night is carbamide peroxide, polar day is hydrogen peroxide.
Perfect. Then the polar day, you get a 4 syringes kit, you get a 10 syringes kit, and you get a 50 syringes kit, day or night. So the 4 syringes kit is on promotion for 445 Rand, and the 10 syringes kit is 710 Rand for the 10 syringes pack. And then if anyone is interested in the Luminate, which is the polar pen, they are on promotion for 400. Let me just double check. The normal price is about 600 Rand. The promotion price is 475 Rand for this evening. Let me just check if we've covered all the questions. No, just compliments, Dr. Sulieman. So thank you very much for your time and your knowledge and sharing that with us this evening. I've learned a lot doing whitenings and knowing quite a bit. The double technique, internal, external bleaching, that was very, very good. Thank you very, very much.
Thank you for spending.
Thank you. Then, thanks to all our delegates. Have a good evening. Thank you. Bye.